Last but not least, Dr. George Kanakis, MD, PhD, is an endocrinologist, clinical andrologist, certified by the European Academy of Andrology. He is currently a consultant physician at the Department of Endocrinology of the Athens Naval and VA Hospital and the IVF unit of the Greek Armed Forces, with a special interest in reproductive endocrinology, andrology, and ultrasonography of the male genital system. He is a member of the writing group of the European Association of Andrology Guidelines on the Evaluation and Management of Gynecomastia, and the shared document that we mentioned at the start, the European Menopause and Andropause Society position statement on testosterone replacement therapy in older women or in older men, which has been endorsed by the European Society for Endocrinology. He is currently the president of the Hellenic Society of Andrology up until 2025 and chair of the Committee of Reproductive Endocrinology of the Hellenic Endocrine Society in Greece, which is ending in 2024. We like to invite George in order to start his interesting, rather challenging presentation. And I will have a question already for you when you're done with the presentation. Thank you, George.
Dear Elena, thank you very much for your kind introduction. I would also like to thank the committees of the ESE and the EMAS for this invitation to be among so esteemed colleagues in this outstanding meeting. And what I would like to share with you in the next few minutes is the steps that we need to do when not to stimulate the male reproductive organs, as we have heard so far, but when there is need to suppress their function. And this is what we are called to do when talking about male contraception. So it is more than relevant nowadays that there is need to improve our current contraceptive methods because the world population has grown enormously, particularly affecting the less developed countries. And on the other hand, even in the developed countries, more than half of pregnancies are unintended. And sadly, more than half of these unintended pregnancies will end up in abortions. Therefore, there is a definite need to reconsider the existing attitude towards contraception. And what is the current attitude? It is that women bear most of the contraception burden. Even in developed societies, only 1/3 of couples rely on male contraceptive methods. And when talking about these methods, we often include unreliable methods such as withdrawal or planning, which is slightly better than just leaving it on chance. Are couples ready? Are men eager to participate equally with their partners in family planning issues? It's true that almost 30 studies in the last 20 years show that more than half of the participating men are eager to use a new contraceptive method, depending on their cultural beliefs, of course. And interestingly, more than 90% of women would rely on their partner to use a contraceptive method. Well, this sounds very optimistic because still we have limited choices, and these are the well-known condom and vasectomy. We will talk about hormonal contraceptives and mechanical vasocclusion, which are still in clinical trials, while what else you will hear about is still in preclinical development. And the reason for this is that there is a lack of pharma industry involvement and lack of opinion makers that will advocate for male contraception. It is something that is hopefully optimistic that the landscapes seems to be changing as the issue of male contraception gains particularity the most recent years, particularly after the Dobbs case, which has changed the recent legislation over the Atlantic, which set constraints on access to safe abortion. So both partners should be cautious. And international organizations such as the WHO, public programs and charities such as the Bill Gates and Melinda Gates Foundation are eager to support research on male contraception. Under this perspective, the European Academy of Andrology and the American Society of Andrology have recently published the practice and development guidelines on male contraception, and we are really happy to have together with us Professor Goulis, who is among the senior authors of this guideline set. The aim of these guidelines is to review the current status of male contraception and to set the present state of the art to support the clinical practice regarding the currently used methods. However, we must admit that most discussed methods are under development still. What about the existing contraceptive methods? The condom, for example, it's the most popular and the most ancient, we should say, method. Its proper use is said to have a 10% failure rate. However, its everyday use is not so effective. The real data, the real figures are about 20% failure. However, it is true that is the best way to protect against sexually transmitted diseases. So in these recommendations, there's a strong recommendation about the consistent and correct use of condoms, especially when there is a risk of sexually transmitted infections, and if there are contraindications to other methods. What about vasectomy? This is not so popular. It is selected by mostly 3% of couples, and it is most popular among developed societies and men of higher education. It has really low failure rates, and its efficacy can be realized 2 to 4 months after the procedure if we realize that there is a sperm concentration of less than 100,000 per ml. It is a procedure with mild complications. However, we should warn our patients about its poor reversibility. So as we see, we have only two methods currently available for men, and they are very far from being ideal. So alternative methods have to be developed. The methods that is more closely to get most close that we can get to commercialization is male hormonal contraception, and the concept of this type of contraception relies on the physiology of the gonadal axis, as you have been informed in the previous excellent talks from my colleagues. However, for this purpose, we go the opposite way. So what we need is to block the secretion of GnRH and gonadotropins in order to shut down the testicular output. And if this happens, then we may have hypogonadism, which we have already seen that is detrimental for men. So we have to add exogenous testosterone, which has the principle, has the ability to suppress the gonadal axis while maintaining at the same time androgenicity. This concept has been tested almost 30 years ago in 5 trials supported by the WHO, and the lessons that we have learned from these studies is that if we get really low to spermatogenesis suppression, which is less than 1 million per ml, then we can have effective contraception, which is similar to that achieved by the contraceptive pill for women. And we also realized that this suppression can be fully reversible. So the first conclusion is that testosterone exogenous admission works as administration works as a contraceptive. However, there are still unanswered questions by this trial. The first question is that there are 3 to 10% of men who are not responders and do not reach the desirable grade of oligospermia, despite the complete gonadotropin suppression. Currently, there are no safe predictors for this response. The polymorphisms of the androgen receptor and the ENCL3 levels have been proposed, but this is not something that is unequivocal. And a second question is why this type of suppression is more effective among men of Asian origin. Some have suggested that the Asian diet that includes much of phytoestrogens contained in soya is the reason for this. Uh, so, researchers tried to use progestins to improve the overall response rates, especially among Caucasian men, and to offer a faster and more complete suppression of spermatogenesis. And this was true in the initial trials, which showed that this combination of progestins with testosterone to maintain androgenicity was more effective and rapid, and that lower doses of androgens were needed to achieve this. In this slide, we can see that various combinations were tested, and the one and only study of male contraception that was funded by the pharmaceutical industry is included in this slide. It was considered by testosterone andecanoate and entonogestrel. However, despite of having interesting results, it was prematurely terminated, mainly due to withdrawal of the sponsor's interest. Interestingly, 10 years ago, this use of a combination of testosterone and progestins was studied in trials supported by the Population Council and the National Institute of Child, and it proved to be very effective and refueled the conversation on male hormonal contraception. The progestin was used nesterone, which is a non-androgenic progestin with minimum side effects. And the gel approach offered more independence and less discomfort, so it was widely acceptable by the participants. Based on these promising results, a phase 2 study tested this combined gel, and this study included a 2-year efficacy phase, which is expected to be concluded by the end of 24. And the preliminary results were presented last summer in the Endocrine Society meeting in Boston. The very interesting result was that there was a really fast median time to suppression, which was less than 8 weeks. And nearly most of the participants had achieved suppression by 15 weeks. No major safety concerns have raised until now. There are some questions about the compliance of a daily gel approach in real-world use and the possible transfer of testosterone to a partner or a child. To get back to the guidelines, there is a recommendation against using this type of hormonal contraceptives in men less than 18 and more than 15 years old. And the reason for this is that men out of this range were not included in the trials. And there's also a strong recommendation to follow the latest guidelines on testosterone replacement therapy regarding the contraindications and follow-up. What is interesting is that the semen analysis is not routinely required before initiating hormonal contraception, and this is based upon the proof of reversibility in more than 99% of men, and to the fact that the Guidelines Committee paid a high value on avoiding potential barriers to accessing male contraception compared with the females. The contraindication of testosterone administration are divided into absolute and relative. Absolute contraindications are breast cancer and untreated prostate cancer, while relative ones are severe heart failure, a recent major acute cardiovascular event, a personal or family history of venous thromboembolism, severe obstructive symptoms of the lower urinary tract, and polyerythrocytemia, which is a hematocrit more than usually 50%. How we should monitor this contraception therapy? This monitoring consists of two phases. The first initial, which is the suppression phase, which usually lasts for 12 weeks. And until this phase, we have to check if suppression of sperm concentration have been achieved below 1 million sperm per ml, and to check if hematocrit exceeds 54%, or if there are any relevant increases in PSA levels, or if there is a novel finding in the digital rectal examination of the prostate. Then, if suppression of spermatogenesis is achieved, we enter the efficacy phase, where the couple is allowed to use this contraceptive method without using any adjuvant method. The concerns about hormonal contraception are its slow onset. However, we saw that the gel combination is faster than previously reported. Its slow reversibility, although it is full. The emergence of acne of alopecia, mood disorders, a drop in HDL cholesterol. However, recent studies in testosterone replacement therapy have shown that this is safe even in older patients. There always will be prostate health concerns, although we should say that the attitude in this field has been changing. And the fact that the parenteral administration makes hormonal contraception less popular. And we see in this slide that many men would prefer the development of a hormonal contraception pill. However, this is impractical because oral testosterone, regarding its older forms, was hepatotoxic, and regarding its newer forms, it should be always ingested with food, and multiple doses are needed to get suppression, making it impractical. For this reason, new modified oral androgens have been developed, such as dimethandrolone and 11-beta-methyl-nortestosterone, which can activate both androgen and progesterone receptors. They do not require a reduction to act, they do not aromatize, and in order to differentiate them a bit, DMA is more potent as an androgen, while 11-beta-MNT has a more balanced progestin to androgenic activity. The aforementioned concerns about hormonal contraception underscore the need for alternative methods of male contraception, which should have a quick onset and be readily reversible with no side effects. Such properties are more probable to be achieved by non-hormonal methods, which may cause disruption of the sperm transportation, inhibition of spermatogenesis, or incapacitation of spermatozoa in order to reduce their motility or their fertilization capacity. A major target is the disruption of sperm transport in the ejaculate, and this can be done either by pharmaceutical or by mechanical means, such as the intravasal hydrogel occlusion. It has been many years that the reversible inhibition of sperm under guidance, it's called RISUG, was developed in India, which consists of a polymer gel which is injected into the vas deferens and can block the lumen and disrupt the patency of sperm. It has been already tested in phase 1 and 2 trials in India, and in a recent phase 3 trial of 140 men approximately. It was really effective, reaching azoospermia within 18 days with really low failure rates. It proved to be easy reversible. However, there are still concerns about its potential reproductive toxicity. An equivalent has been developed in the United States. It's called the Valsagel, or its a commercial name is Adam. However, it's still in the stage of investigational device exemption, which means that it has to be approved by the FDA in order to be used in clinical trials first before getting in commercialization. Pharmaceutical non-hormonal contraceptive methods are the well-known alpha-adrenergic blockers such as prazosin, tamsulosin, silodosin, which cause an ejaculation due to inefficient coordination of the muscle layers of the vas deferens. They need at least 5 days to take effect, and they reach azoospermia in almost 18% of cases. However, they have unpleasant side effects such as dizziness, tachycardia, and nasal congestion, while this feeling of dry organs without ejaculation is not always tolerated. And there are also concerns about the long-term sperm storage, which may cause a genetic alteration or lead to the development of anti-sperm antibodies with detrimental effects on fertility. Another substance that may cause inhibition of spermatogenesis and has been extensively tried in China is gossypol. This is a phenolic compound derived from cotton seeds, and it was tested in the 80s in more than 8,000 men. Huge population. It resulted in severe oligozoospermia in 90% of participants. However, it proved to be occasionally irreversible, and in sometimes it caused hypokalemic paralysis, which was something really dangerous. So to sum up, the facts about male contraception are that women still bear most of the burden of contraception and family programming. Men seem to be willing to participate in family planning. However, the truth is that currently we only have 2 contraceptive methods: condom and vasectomy. If we check the other methods that are under development, we should say that hormonal contraception have come closer to commercialization, while non-hormonal contraceptive methods, although are very promising, they are still experimental. So what is obvious is that there is a need for funding and awareness in order to start this new era in male contraception. Thank you very much for your attention.
Thank you very much for the interesting presentation. Actually, I was hoping to ask a question, but you explained everything, so there is no need for me to ask. And we can go ahead with Q&A. I will start with question number 1. It was related to the first presentation, but I will open it up to all of you. The question is, should testosterone be given in patients with heart failure, with ischemic heart disease, in somebody who has hypogonadism? So can we actually replace testosterone in somebody who is hypogonadal but has also heart failure with evidence of ischemic heart disease? What do you think? Not only you, George, all of you.
So, since I've got, I don't know, I think that Professor Goulis would like to add something.
Oh, anyone, George, let's try to have quick answers. The answer is yes, you can supply testosterone in men with cardiovascular disease. I would avoid to do it in very acute cases, just immediately after an event, but after some week, there is evidence that it's safe. I would be careful in severe heart failure classes 3 and 4, according to the New York Heart Association. Thank you.
Thank you very much for this answer. I will continue with question number 2. The TRAVERS sub-study has shown no difference in progression from pre-diabetes to diabetes between testosterone and placebo. Is there other data? Can you comment on whether testosterone treatment offers benefit in patients with pre-diabetes?
Maybe I would answer this. Well, the problem when assessing diabetes or prediabetes in testosterone trials is that glycated hemoglobin is concurrently the endpoint and the confounder. Because we all know that when we administer testosterone, hemoglobin is raised, hematocrit is raised. So glycated hemoglobin is not so accurate in order to consider these results. The type 4DM study that used the oral glucose tolerance test proved that there was positive effects in prediabetes prevention. But also in this study, glycated hemoglobin did not confirm this.
I am covered on my behalf, but anybody who wants to add anything else? We're good to go.
Okay. Moving to our next question, and it's which formulation of testosterone is best to start with in functional hypogonadism?
Let's have once again a quick answer. It's gel testosterone, and this way it's from gel that we have the best data. The T trial, which is the main trial for efficacy, and the TRAVERS study, which is the main trial for safety, were performed with gel testosterone. So we have the data for this.
Great. And then another question. If using gel, should the serum testosterone be measured before or 1 to 2 hours after the therapy?
So let's finish this. If you use injection, you are going to measure usually at the trough level, that's before the next injection. So trying to have a low normal concentration. But if you use gel, we usually measure 4 to 6 hours after application. More often than not, it's a morning application. So you apply testosterone gel in the morning and you measure it 4 to 6 hours later, so during lunch. Thank you.
Thank you very much. Our next question is, does testosterone replacement is effective across entire obesity spectrum, especially grade 3 obesity, not only in terms of hypogonadal symptoms, but also on metabolic and body composition?
Unfortunately, we have lost water at the moment. Who would be ideal to answer this question? If anybody wants to fill in.
I mean, testosterone it's not an anti-diabetic medication. Most probably you will have some benefits in terms of glucometabolic defect, but it's not for this purpose. So it will help. You can use it. Grade 3 obesity is not a contraindication for using testosterone, and you may have some benefits concerning glucometabolic issues, but of course we have other medications for diabetes treatment. Thank you.
Thank you very much. We will continue the discussion around obesity. It looks like there is great interest out there. So we have a question that is stated as such. Depression is more prevalent in obese people. Is there any relation of increased risk of MOS in obesity with depression, anxiety, as opposed to obesity without mental health issues? What do our experts think? Perhaps Professor Goulis, you can help us with that once again?
Sorry, remind me about MOS. I missed the abbreviation. MOS is?
It's metabolic...
Male onset secondary hypogonadism.
Male onset secondary. So functional, eh? Depends on if there are any relation of increased risk of MOS in obesity with depression, anxiety versus obesity without mental health issue. I have difficulty in understanding the question.
I think that there is for two reasons. One is because of the mental health problem, and the other is because of the treatment that is usually used for treating depression and anxiety. So definitely yes.
Thank you.
Thank you.
And for the next question, the audience is asking, do you think high SHBG with normal total testosterone is accompanied by a decrease in free testosterone? High SHBG without a decrease in total testosterone can be a cause of hypogonadism? So ultimately, as to whether or not SHBG levels with, I think the phrasing is a little bit difficult in order to understand the question, but SHBG levels without a decrease in total testosterone levels as to whether or not the single isolated changes in SHBG could be a cause of hypogonadism.
If I get the question right, I think that the issue is that if we should consider someone hypogonadic, if he has normal total testosterone, but he has low free testosterone. This is the result when you have total testosterone with high SHBG levels. However, the problem with considering and diagnosing hypogonadism is that you should realize when the individual is helped when administering testosterone for his problems. So there are no trials that have shown that people with normal total testosterone would be benefited by administering testosterone. So this is a gray zone. I think this is still a gray zone, and we should be very, very discuss it by case by case.
Thank you.
Thank you. Our next question is, we frequently encounter leukocytospermia in semen analysis of infertile male without any symptoms of genitourinary infections and semen culture and urine analysis consistently normal. Does LCS has any negative impact on fecundity? Should we ignore LCS without symptoms or empirically treat those patients?
Yeah, I can answer to this. I think that leukocytes obviously could influence the quality of the sperm, and so this is obviously detrimental for the sperm quality and so for the fertility. And there are cases of alteration in leukocyte number without any symptoms. In this case, I am not so in favor to a treatment, and antibiotic treatment empirical is not so good. But in this case, also considering the role of nutraceutics and so antioxidants could be useful to decrease, because the leukocyte increase the stress, the oxidative stress, reducing the sperm quality, and so the treatment should be moved on the consequence of the leukocyte.
Thank you very much. Another question. I have a question regarding transgender people, male to female, who wish to conceive. Although we offer them cryopreservation of sperm before introducing estrogens and antiandrogens, some patients decide to undergo cryopreservation during the hormonal therapy. How long should the therapy be stopped to get a safe sample that is not contaminated, that is altered with antiandrogens?
Well, it is difficult to answer this. You have to take under consideration the half-life of the medication. It's not an easy thing. Of course, there are no data about this, but I would say that I would consider to stop medication for 2 or 3 half-lives and see if there is sperm. You said male to female, to see if there is sperm there, and then we can cryopreserve it. So this is very important to take this decision before starting genetic hormone assignment therapy. Thank you.
Thank you, Professor Goulis. Okay, another question is, how can we improve teratozospermia with normal sperm count?
Great question. It's not so simple. There is no one single answer. Also, in this case, nutraceutics and antioxidants could be useful. We have many, very huge number of nutraceutics, and the decision of the best must be important. In Italy, is the situation in which we can use FSH as a treatment. So this is the case in which FSH could be used to treat infertility, also when normal sperm count is detected, but with reduced quality in terms of motility or morphology. And so in Italy, it's quite more simple, although it remains an empirical treatment. But otherwise, nutraceutics could be useful, at least in this situation.
Thank you very much. I will just move on with something I also find interesting. Please clarify what diagnostic tactics are used when viscosity increases, I presume in the context of testosterone replacement, and also how do you proceed in the case of idiopathic asthenoteratozospermia in the absence of female infertility?
For therapeutic point of view, the answer is the same as previously reported. From diagnostic point of view, when viscosity is high, first we have to repeat the analysis, and then to search for anti-sperm antibodies. But from a diagnostic point of view, the search for infection or inflammation is the topic that we have to focus on.
Thank you. And a question addressed specifically to Dr. Kanakis. Few young people seek consultation for anabolic androgen steroids for muscle strength endurance purposes. We always advise against its use as it is not physiological. Could MHC be advised to such people who are not concerned for fertility solely for purpose of muscle building with close follow-up?
That's a very interesting question. Still, we need trials to see what is the long-term safety of contraceptive therapies, because it is something supraphysiological. There is no hypogonadism. These men are are normal. So, yes, you can do it as long as you have data that show you that this is safe. but you cannot do it in longer terms than these trials have been conducted. In general terms, we should be very, very cautious. And first of all, we have to see what is the psychological background behind these young men who have a dysmorphic opinion about their body, and to not support this kind of misconception that they have.
Thank you very much for this interesting topic. And I think we are over the time, so it's about time to summarize this webinar. On behalf of the European Menopause and Andropause Society, I want to thank my co-chair, Christina, the European Society for Endocrinology, and all of you for being with us today during this very interesting webinar, and to giving us the opportunity to discuss all of these topics, address the questions, and just a big heartfelt thank you from my side. Christina, back to you.
Thank you, Eleni. I'm joining to your words. Foremost, I would like to thank the speakers for enhancing the platform for male reproductive health, which is very, very neglected and highly important. And I would like to thank all the participants, the residents, the early careers, the mid, late careers, nurses, scientists, everyone who joined today. Because I think that, I mean, our spirit and our motto is that the only way to grow is together. So thank you to all of you. Thank you for joining in such a high number. We had participants from 6 continents, 74 countries, exceeding 470 and 70 registrations, which I think is a huge success for all of us. So on behalf of the European Society of Endocrinology and the Early Career Committee ESE, I thank all of you, and stay tuned for all the upcoming events, and hopefully we'll be able to have another one on male or female reproductive health soon.